And today we're going to speak about sonopathology of the ankle tendons and the ligaments. And we won't be discussing the Achilles tendon because that's a topic which is being discussed a lot. And I just want to focus on some other structures in the ankle and foot region. So maybe you can make a print screen of this or a picture of this link. You can download the handout on this link, and this handout not only contains this presentation, but also a little bit more slides, which we won't discuss today. So this is a link you want to check out. Maddie already introduced me. Next to my clinical work and my work at Sonoskills, Maddie talked about. I also want to mention that I'm also the proud owner of ultrasoundcases.info, at least about owner of the content. And it's a free website with more than 7,000 ultrasound cases. And the page is now quite old, but we will relaunch it in September, brand new. So let's discuss the tendon pathology of the ankle joint. So first I want to discuss a little bit how we at Sonoskills train our participants in pathology recognition. So first, and for this we use the pathology checklist. The checklist has actually two parts. First, on a structural level, as you can see here, we are going to assess several points. So first, the shape. Did the morphology change? For example, is a tendon, has it increased in thickness or maybe decreased in thickness? We are going to look at the echogenicity. Is the echogenicity different? Is it more hyperechoic or more hypoechoic? Which tells you also a little bit about the quality of the tendon or about the anatomical tissue. Then the third checkpoint is, how is the continuity? Are there any tears of fiber discontinuities? Is there a partial tear or a full thickness tear or a complete tear? And then we're going to check with Doppler to see for neovascularization. Tells you a little bit about the inflammation process. But also very important, and I think this is where ultrasound has a great benefit, functional. How does the anatomy move? So while scanning, try to move the tissue and see how it goes. So this checklist is used for pathology recognition, and you can use it for tendons and muscles and nerves, even for, partly for bone. So all kinds of tissues can be checked with this checklist. And after you think that you saw pathology, then you want to make sure that it actually is pathology. So to make the right interpretation, always scan in two planes, longitudinal and transverse, long axis, short axis. Left-right comparison is very valuable. It brought me lots of clinical feedback actually. You can measure, of course, your changes and always decide how relevant is actually the change. So with this checklist, I'm also going to explain you more about the ankle joint pathology. And before we do that, I also want to show you this article. I think this is a really good article written by lots of radiologists, all part of the European Society of Radiology, and they are also part of the ESSR. And they made in 2017 an update of their article about a consensus statement on which tissues in the ankle joint do make sense to test with ultrasound and which actually don't make sense. For example, this table, which you can see here, they did a consensus in 2012. They revised it in 2017. And for example, let's start with above tendinopathy. It has a level 3 in 2012, and 3 is the highest the article can get, or this disease can get. 0 is the lowest. And in 2017, all radiologists still were agreeing on that a tendinopathy scores a 3. So a tendinopathy you can really check well with ultrasound. So let's go for a 0. the posterior talofibular ligament does not make any sense to scan with ultrasound. So ultrasound is not a golden standard for that, and best is actually not to do that. So you can go over the list, download the article, and yeah, see which indications make sense to check out and which don't make any sense to check out. Let's first have a look at the anterior compartment. So the anterior compartment containing the tibialis anterior, the extensor digitorum longus, and the extensor hallucis longus. So I think it's a compartment which is not as much involved in pathology than other compartments in the leg. So it's less involved, but from the structures inside this compartment, this anterior compartment, I think that the tibialis anterior tendon is the most commonly involved one. And this, you can see that on this slide that these tendons are covered with a retinaculum, the superior retinaculum, and also an inferior retinaculum. And this is quite a vulnerable spot for, yeah, at least the tibialis anterior, because we can see in many cases tears in this region, sometimes partial, sometimes also complete tears. And in this case, you can see that let's use the checklist. The shape of the tendon has changed. We see on the right side of the upper image a very thin tendon. It has decreased in thickness. Maybe it isn't even a tendon, what we can see there. And on the left side, we can see a very thick part of the tendon. It has increased in thickness. We can also see that part has changed in echogenicity. It's much more hypoechoic and also partly anechoic. And the continuity we can see has been lost. So this is a complete tear with retraction of the anterior tibial tendon. There is no Doppler imaging here, so I can't say anything about that. And there's also, it's a static picture, no clip, so I also can't say anything about the functionality. But this is a complete with retraction. And this happens mostly in the superior part or around the superior retinaculum. More distally, at the insertion of the medial cuneiform bone, the tibialis anterior does not tear that often, but you see more tendinopathies. So in this, you see a left-right comparison, left healthy, right affected, and the right tendon has been is thicker, the shape has changed. Echogenicity is positive because we see a more hypoechoic. Continuity, we can see that it's still intact, so it's not a tear. Doppler again and functional movement cannot be checked in this slide. If we see a pathology, always check in two planes, always short axis, long axis. Only if you can see in two planes the same pathology, then you can say it's a pathology. So in this case, it's a tenosynovitis of the anterior tibial tendon. We can see that the tendon itself is quite okay. It looks okay, but around the tendon sheet itself has increased in thickness, so shape has changed. We can see that within the tendon there is, or within the tendon sheet, there's a anechoic mass. This is a fluid surrounding the tendon. The tendon is still intact. The continuity is okay, but there is a Doppler signal. So it's an active inflammation process, and this is a tenosynovitis of this tendon. In lesser degree, not as much as with the tibialis anterior tendon, you can sometimes also see tenosynovitis of the extensor digitorum. And in this case, it's a beautiful image of Park et al. In 2017 published. And we can see this huge anechoic mass within the tendon sheet, this infusion of the tenosynovitis. And look at the bottom of the slide, and you can see that within this consensus statement, the radiologists of the ESSR score this. Sheet effusions can be checked with a tree. So ultrasound, very good for sheet infusions. And this is longitudinal, so let's look at it in a transverse way. It's the same image or the same structure, and also here it can be confirmed that there is actually a fluid mass around the tendons. So I think that's what is very challenging, is that you have to think in different professions, not only from a radiology perspective, but also sometimes from a rheumatology perspective. So I think as a sonographer, you need to be aware and known with many diseases on a different level. So, and in this case, what is pretty typical is the little hyperechoic foci, the little hyperechoic reflections in this tendon, in this extensor digitorum tendon, and this is actually quite typical also for crystal arthropathy and gout. So we can also see that there is a positive Doppler signal, so it's also an inflammation process going on. So yeah, be aware of also that diseases, other diseases, that hyperechoic reflection is not always just a calcification, but sometimes it's a cue or a clinical sign for a disease process, a specific disease process. In this case, this is an anterior impingement. So what we can see is on the left image, we can see the tibia and the talus. So this is the talocrural joint. Same thing also in the right image. It's a different ankle, but with a sort of the same pathology. So looking at the shape of the bone, we can see that in both images, the talus has a extra convexity, a spike on top of the talus, a piece of bone, a spur, which is going to impinge with dorsiflexion. And in some cases, this spur can even rub or friction with the tendon, and causing also the tendon changes, which you can see in the right picture. So going to the lateral compartment, this is the compartment where we can find the fibularis longus or the fibularis brevis, as synonym the peroneal tendons, peroneus longus and peroneus brevis. And especially these ones are more commonly involved than some of the, or actually than the anterior compartment tendons. So this is more regular. So let us look at the peroneal tendons and also for some weak spots in the trajectory they have. So let's start at the dorsal side of the lateral malleolus. So the peroneus brevis has quite a long muscle belly. The tendon of the longus is already tendinous. And in the middle image, if you go slightly deeper in the middle image, you can already see that they are both tendinous. And the bigger one is the longus. The longer but thinner one is the brevis. And the brevis is more closer to the bone. I will say a little bit more about that later. So then if you follow the tendon to distal at one certain point, you will see the right image, and that's actually the peroneal tubercle or peroneal tubercle, splitting the longus and the brevis tendons actually in two, right? So they are being separated, and that is actually quite smart of the body, because the longus at that point goes to the plantar foot, and the brevis continues and the lateral foot towards the base of the fifth metatarsal. So that's also a weak spot. So in this case, we can see both the tendons and the behind the lateral malleolus. And if we look at the right image, then we can see that the tendons are actually subluxated. And in this case, that has been checked with a dynamic scan. So by plantarflecting and dorsiflecting the foot with eversion and inversion, you can actually stress the tendons dynamically. In the left image, they appear to be okay, but while moving, you suddenly see them popping over the lateral malleolus, meaning that the stability mechanism has been torn. This retinaculum, which holds the peroneal tendons in place. And this can have several factors. So there are numerous reasons why this retinaculum can tear. Again, at the bottom of this slide, from the article from the ESSR radiologist, you can see peroneal dislocation is a disease process which you can see very well with ultrasound. So you can definitely see that. So if we're looking at the peroneal tendons, we could see potentially a few different pathologies. For example, in this case, we see a tendinosynovitis and also a partial tear. So we can see an increase in thickness of the whole tendon sheets with anechoic mass, fluids surrounding the tendons. There is Doppler activity, and we can also see a diffuse thickening of the tendon of the brevis, the short one. And in this case, you can see really within the tendon. So let's go over the checklist again. Shape, the tendon has increased in thickness. Then the echogenicity, it's anechoic, partly also hypoechoic. And looking at the continuity, we can see that there is partial tearing within the tendon. And this happens quite a lot in the peroneal tendons, this partial tearing. This partial tearing can also occur over time in the brevis. It can occur over time, and sometimes it is due to loading of the longus and having a high load pushing against the brevis, and with such a force that the brevis is being split in the end, so that the brevis will be splitting in two with the longus in between. So this is a disease process which happens over time. If it happens, patient will have pain, but in the end this becomes the normal situation, and people are also asymptomatic if they have this. In this case, it's not asymptomatic. So in this case, it's probably a situation where it's painful. It's a pre-split situation. We can see that the longus is already pushing a little bit against the brevis. We can see also some Doppler activity. And if this happens long enough, then we can see really a split. So, and this can especially be seen in the right image. So we can see that the longitudinal fibers of the brevis are a little bit like a fork, and within between we can see the fibers of the longus. So we see actually 3 tendons instead of the usual 2. I say usual, so in most cases it's usually 2. Some people have a peroneus quartus, that's anatomical variation, but yeah, that is not that much occurring. So if we glide from the lateral malleolus towards distal, then right a little bit distal from the malleolus, then we come at a spot where we can see the peroneal tendons in a tendon sheet, and underneath the tendon sheet there we can find the calcaneofibular ligament, the ligament between the stabilizing ligament between the calcaneus and the fibula. And this is a very nice and cool transducer position, I think. You can assess the ligament, but you can also assess the tendons. Sometimes, if you're not sure if the ligament is intact, then you can dorsiflect and invert the foot, the ankle and foot, And what happens is actually that the ligament underneath the tendons will tighten, will be stretched with this movement. And while the ligament is being stretched, you will see a superior moving of the peroneal tendons. So it's like a hammock being stretched, straightened, and this pushes up the content. So this pushes up the tendons, the peroneal tendons. So if you see the tendons moving when moving upwards, then you know that the tendon is still intact, pushing from underneath. In this case, a lot of Doppler activity and also swelling of the peroneal tendons. So this is the peroneal tuberosity. The peroneal tuberosity, if you scan the tendons, the longus and the brevis, then in most cases you won't see them equally nice in screen. They have a little bit already a different fiber orientation. So if you have a good echogenicity of the longus, the brevis is hypoechoic, and vice versa. If you have a good echogenicity of the brevis, the longus is quite dark and hypoechoic. But in this case, we can see that within the brevis, you can see the yellow arrows pointing to some very dark anechoic clefts or tears. So these are little partial tears of the peroneal tendon. And in this case, we can see two tendons, the peroneal tendons, both on one side. So meaning that there is a subluxation of the longus over the peroneal tubercle towards the brevis. We can also see that the tendon sheet, the retinaculum, the tendon sheet, is thickened, increase in thickness, and some anechoic fluid. So this, I'm not ready yet, but just wanted to point out, if you are interested in workshops in the US or somewhere else in the world, ultrasound-guided injection workshops, or pure focus on ankle-foot workshops, or foundational general MSK workshops, you can subscribe to our newsletter and we will update you when we are in your area with our courses. So let's have a look at the deep posterior compartment with the flexor digitorum, the posterior tibialis, and also the flexor hallucis. So looking at the content of this deep posterior compartment, especially interesting to see at the medial ankle in the tarsal tunnel region, and there we can find Tom, Dick, and very, very nervous Harry. Meaning that we can see from anterior towards posterior, the tibialis posterior, the flexor digitorum longus, the tibial artery, the tibial vein, there are two of them, the tibial nerve, and lastly, in the very posterior is the flexor hallucis longus tendon. And these tendons, if you look at the red arrows, they all have tendon sheets. And and they are tendinous. If you look at number 8 in the middle of the screen bottom, this is the flexor hallucis. The flexor hallucis is partly muscular there and partly tendinous. And I think that from these three tendons, the most one that is affected is the tibialis posterior. So I think that after the Achilles tendon, the second one, the most commonly involved is the tibialis posterior. The third one is the peroneal longus, and the fourth one is probably the tibialis anterior. And in flat foot deformity, also the tibialis posterior has a lot of stretch, and in some cases will also tear. So this is the tibialis posterior tendon. So you can see, a little bit similar as with the peroneal tendons, effusion in the tendon sheet, Doppler activity, anechoic mass, and in this case we can still see that the tendon is intact. There is a little partial tear there, but it's definitely not retracted or completely torn. So here we can see a tenosynovitis of the flexor hallucis longus. We can see that the flexor hallucis longus is is swollen. We can see a swelling around the flexor hallucis, and in some cases this can cause quite a problem, because this fluid mass indicated here with the asterisk symbols can push, for example, the tibial nerve, indicated by the white arrows here, against the retinaculum of the tarsal tunnel. So similar like in a carpal tunnel, in this case the tibial nerve is compressed at the tarsal tunnel retinaculum. So let's have a look at some ankle ligament pathology slides. The ankle joint has many ligaments, but let me focus on a few. The most commonly involved ones: the calcaneofibular ligament, the tibiofibular ligament, and the talofibular ligament. So looking at the bottom of the slide, we can see the anterior talofibular ligament is scored with a 3 by the ESSR consensus committee, and the posterior talofibular ligament is with a 0. So don't do the posterior talofibular ligament. I wouldn't do it. But definitely check the anterior talofibular ligament out, because you can see it very well. In this case, we can see that the right side is affected. The right side shows a hyperechoic part in the tendon, and shows also a partial tear of this ligament. In this case, it's a complete tear. So looking at the shape is totally changed, right? Anatomy is not recognizable anymore. We can see a lot of anechoic mass, fluid, and we can also see that the fiber showed no continuity. So it's a complete tear of the talofibular ligament. And with all ligaments, so functional assessment, checkpoint 5 on the list, is really important. So always stretch the foot or the ankle and try to tighten the ligament. And sometimes you see a huge gapping showing that the ligament is dysfunctional. But also in some cases you think that the ligament is intact, and only with stressing the ligament the tear opens. So I can really recommend you stressing the ligaments, actually every ligament, while scanning it. The calcaneofibular ligament at the bottom of the slide, you can also see it's scored with a 3, so it's definitely a ligament which you want to check out. It is a little bit complex to scan. It has quite a 3-dimensional orientation, but once with a certain learning curve, you can definitely, with high accuracy, diagnose tears in this region. And if you see a fluid around the peroneal tendons, always check out: is this fluid from the peroneal tendons, or is this a fluid actually from the joint? A joint problem, ligament tear, the fluid from the joint wraps around the tendons. So do this hammock stretching, what I explained earlier. Tighten the ligament and see if these 2 tendons will move upwards with stretching the ligaments, and then you know, okay, ligament is intact. If they don't go up, but if they go down, if they fall down, then you know ligament is not intact, and the fluid is probably a result of the ligament tear and the joint problem. The tibiofibular ligament, number 3 in screen, is also a ligament which you want to check out. And in this case, we can see a complete tear of the ligament. You can see that the left side is healthy, the right side is affected, and you can see that the nicely aligned fibers of the left side are not recognizable anymore in the right image. And also here, always check it out with a functional movement. For example, this anterior tibiofibular ligament, you can check in the left image with a squeeze test, or in the middle with a dorsiflexion test, or with compression on the right side, which give you extra clinical information and also about the clinical relevance. The deltoid ligament, people ask me, Mark, do you scan the deltoid ligament? Well, in many cases, I do, but I think ultrasound is not the golden standard for the deltoid ligament. The deltoid ligament is quite a complex anatomical structure. It has very broad ligaments, several ligaments. It does not only have a superficial ligament, but also a deeper one. So there are several layers to the deltoid ligament. And the ESSR consensus team scored the deltoid ligament with a 1 in 2012 and with a 2 in 2017. So there are a little bit mixed feelings about this deltoid ligament. I guess it's a matter of specificity or sensitivity. I think if you do see something in the deltoid ligament which is not correct, you're probably right, then there's pathology. But if you don't see anything, you're not sure that there is nothing there. So please be aware with screening and the deltoid ligaments. In this case, you can see a tear on the right side. We can see clearly a disruption of the fiber. So this is a case where I think, yes, so it's clear, but it's not always as clear as this. And there are not always arrows pointing to the pathology. So last slide I want to show you is this is a flow chart. On the white oval circles, if you see the calcaneofibular ligament, if you follow the yellow arrow pointing to the calcaneofibula to the left, first you end up in dorsiflexion and then in inversion. So if you make an inversion and a dorsiflexion, you test the calcaneofibular ligament. If you make an inversion and a plantarflexion, you test the anterior talofibular ligament. So this is a flowchart made by Funk et al. And yeah, it can be helpful for your clinical reasoning and testing functionally.